Any relevant disclosures or conflict of interests. I should clarify I'm a neurointensivist, a neurointerventionalist. I'm not an infectious disease doctor nor a public health expert. At the request of the survivors, the names, ages, and genders have been changed out of respect to the dead. Everything else has been told exactly as it occurred. So as the novel coronavirus impacts lives around the world, COVID-19 or the SARS-CoV-2 has swept across the globe, and we have identified, it's allowed us to identify deficiencies in our treatment approaches. We've rapidly learned to evolve and adapt. In what's clearly a rapidly evolving situation, during this talk, we're going to try to separate the signal from the noise by tackling issues pertinent to anyone taking care of neuro-COVID-19 patients. I was asked to talk about lessons I learned practicing on the front lines, on one of the front lines of the neuro-COVID epicenters between March and May 2020. And I thought long and hard about what's the best way to describe this. And every time I would start, I'd find myself struggling to describe the exact experience and what I learned and how I learned. Came across this video. This is not me. Here, I'm hoping this is going to work. Can you guys see the video?
No, the video isn't working.
We can hear it, but we can't see it playing.
You can describe what we should be seeing.
Yes.
Let me see. I think you'll be able to see this now. So every day I go to work and I think, I'm hoping you guys can see the video now, but every day I go to work and I think, I'm like, all right, so we're going to do this. We're going to get through this day. We're going to try our best to help our patients. And I honestly feel like this guy every single day. And now fast forward almost 3 months into this pandemic, I feel like I feel exactly like this guy now. Probably the main difference is I cut my hair and I've gained significantly more weight than this guy. All right, so we're back. The reason I showed this video is because I wanted to highlight the fact that as much as we think we know, as much as I would like to teach you guys or show you guys or share with you guys the lessons that I learned, I honestly feel like we're trying to stop a train that that's going to stop anyway. We're trying to push a train that is actually working or acting on its own accord. We're really contributing very, very little. So I thought I'd share with you guys a couple of cases and then go into the details of what I think a topic that is near and dear to my heart, which is the how neuro-COVID has actually affected our stroke practice, our endovascular stroke practice, and how we've adapted and evolved. So the first case is a 41-year-old female who's evaluated in an outpatient clinic for an incidentally discovered unruptured aneurysm, 1 centimeter basilar tip aneurysm. The rupture risk for the aneurysm and the risks and benefits of the treatment were discussed at length with the patient. The patient decided to defer treatment for a few weeks so that she could avoid hospitalization and resource utilization during the peak of the COVID-19 pandemic. Fortunately, the patient presented to the ED 1 week later literally a day after she was initially scheduled to undergo her treatment with a viral prodrome a few days prior, and the worst headache of her life, with radiographic evidence of subarachnoid hemorrhage due to a rupture of a basilar artery aneurysm. The patient tested positive for COVID-19 and subsequently required emergent ventriculostomy, coil embolization of the aneurysm, and intracranial therapy or intraarterial therapy in the form of like chemical angioplasty for vasospasm during her 21-day hospitalization. Her hospitalization was characterized by mild acute respiratory distress syndrome, managed with high flow nasal cannula and proning. Case number 2 is a 43-year-old male who had several weeks of headaches and 2 episodes of transient weakness that were concerning for possible seizures or transient ischemic attack. The patient had difficulty obtaining outpatient cranial imaging for these symptoms during the pandemic, as many outpatient imaging centers were closed and because imaging was deemed not a high priority. The patient was found down and unresponsive after not answering his phone after 3 days. Cranial imaging revealed a ruptured arteriovenous malformation with intraparenchymal and intraventricular hemorrhage causing significant mass effect with acute herniation. The patient received an EVD and underwent emergent embolization of the nidal aneurysm within the arteriovenous malformation and subsequently a hemicraniectomy. The patient tested positive for SARS-CoV-2 and progressed to develop worsening dyspnea, required mechanical ventilation. Treatment regimen included hydroxychloroquine, azithromycin, methylprednisolone, and hospital course was completed by septic shock secondary to methicillin sensitive Staph aureus, which responded to treatment with cefazolin. The patient began to tolerating spontaneous breathing trials, but poor mental status remained despite being off sedation. He received the tracheostomy, a PEC tube, and sent to a nursing home. Case number 3 is a 54-year-old with poorly controlled hypertension, developed left-sided weakness while following the stay-at-home executive order, and was reluctant to seek medical attention when given the overburdened hospital systems and the risk of COVID-19 exposure. The patient's weakness progressed to full hemiplegia, and he was unable to contact anyone for assistance as he was isolating alone at home. Cranial imaging demonstrated a massive holohemispheric stroke with significant herniation. The patient also had rhabdomyolysis, renal failure from prolonged period of being down with no oral intake. The patient required an emergent decompressive hemicraniectomy. The patient's COVID testing was positive. He received treatment with hydroxychloroquine, azithromycin, and tocilizumab. The patient subsequently showed signs of recovery and passed conventional spontaneous breathing trial, but was unable to demonstrate normal mental status. Case number 4 is a case again that very sad case. 41-year-old pregnant female at 20-week gestation presented with complaints of fever and cough for 1 week and tested positive for SARS-CoV-2. On examination, she was alert oriented ×3, not aphasic, but with profound neglect. Did not recognize deficits, did not recognize her deficits, had right gaze deviation, but was crossing the midline when tracking, had dysarthria, left hemianus hemianopia. Flaccid left side of the face, arm, and leg hemiparesis with an NIH stroke scale of 14. Patient was given TPA, and neurologic exam deteriorated further to an NIH stroke scale of 26. A CTA demonstrated a large vessel occlusion, and endovascular therapy was successful in removing her right middle cerebral artery clot. Neurologic improvement was noted post-procedure. However, she progressed to develop worsening respiratory failure, requiring invasive mechanical ventilation on hospitalization day 4. She suffered intrauterine fetal demise and demonstrated significant increased inflammatory markers suggested of cytokine release syndrome, with progression to multi-organ failure, including a coagulopathy, renal failure, requiring renal replacement therapy. She was treated with hydroxychloroquine, azithromycin, tocilizumab, and convalescent plasma. Following physiologic improvement and weaning of sedation by hospital day 11, she was extubated and sent to acute rehab. So the reason I share these cases is because over the course of the past few months, we have learned from every single one of these cases. And I would say after almost 15 to 1,600 cases that have gone through West Russell Medical Center and New York Medical College, I can confidently say that although we were more comfortable managing these patients. And I think it's definitely helped us, this pandemic has definitely helped us identify deficiencies within not only our health system, but most of the health systems in the United States. So the neuroinvasive potential of SARS-CoV-2, there's a question about there's a theory that this occurs via the angiotensin converting enzyme 2 receptor, with increasing evidence showing that coronavirus may extend beyond the respiratory tract and invade the CNS with an affinity towards the brain stem. It may be associated with neurologic signs such as headache, nausea, and vomiting. However, it's also been demonstrated to spread via synapse-connected route to the medulla, cardiorespiratory centers, from the mechanical respirators, receptors, and chemoreceptors in the lungs and lower respiratory airway. It remains unclear whether the potential invasion of the medullary cardiopulmonary center is partially responsible for the acute respiratory failure of patients with COVID-19. So in severe COVID-19 induced ARDS cases, patients may rapidly progress into a comatose state. And it's important to identify the altered mental status, which may be due to a neurologic injury versus that due to the ARDS. Emerging cases of acute hemorrhagic necrotizing encephalitis, Guillain-Barré syndromes, and ADEM, anosmia, hyposmia, dysgeusia have all been reported in patients with COVID-19. So ischemic stroke, which is a topic that we're going to talk about primarily because it helped us highlight the issues and the lessons that we learned from COVID-19. It occurs in approximately 5% of COVID-19 patients. Recent reports have emerged of patients younger than 50 years of age with large vessel occlusion and minimal to no symptoms of COVID-19. However, patients with stroke are more likely, for the most part, they're more likely to be older and present with severe COVID-19 symptoms. The mortality rate of patients with severe COVID-19 can range between 20 to almost 100%. Where multiple risk factors for severe COVID-19 have been identified, but severe vascular disease have been shown to be a negative prognostic factor in those with COVID-19. Multiple hypotheses, pro-inflammatory state triggered by cytokines or cytokine release syndrome, which may contribute to vascular endothelial injury, a hypercoagulable state, which may result in extensive thrombosis, or microvascular dysfunction. So as we were slowly accumulating our knowledge, colleagues from the Society of Vascular and Interventional Neurology actually very beautifully highlighted this in a very recent paper published last week in Stroke, as far as like mechanical thrombectomy in the era of COVID-19 pandemic. Now, one thing I will say, and this is again something we learned the hard way, unfortunately, there is no such thing as like an emergency in a pandemic. You always need to take your time to put your PPEs on correctly. You cannot run in to save a life. You might as well, because you might save one life, but you might not. And you might end up being sick and not being able to care for other patients who may need your help. And you may be a patient yourself. So doing nothing, although it may be the hardest thing you've ever done in your life, sometimes that is the right thing to do. And you are limited resources, and it's very important that you must be protected. So drastic changes have occurred over the current COVID-19 crisis. Treatment goals have evolved from providing the best clinical care for patients to providing the best clinical care for patients without overutilization of resources or compromising healthcare worker safety, which is essentially, it's a huge mind shift or culture shift in the way we practice our medicine. Treatment of life-threatening, time-urgent conditions such as acute ischemic stroke and STEMI have always focused on providing correct treatment for those who may benefit as early as possible. The concern of contact with possible COVID-19 positive patients may result in delayed treatment and triage. It's very important to screen your patients and it's important to have a very, very high index of suspicion for COVID-19 patients. For COVID-19, it's important to screen for fever, contact with COVID positive patients, and recent cough should be ideally performed by the 911 dispatchers, and EMT should be performed prior to on-scene arrival. Telemedicine utilization in the emergency department, as well as for inpatient stroke codes, have been utilized to minimize provider contact with potential COVID-19 patients. As far as screening and pre-hospital care, urgent lab draws and rapid bedside testing for COVID-19 should be performed on arrival, and if doing so will not result in a delay more than 5 minutes, while we're obtaining imaging, at this point, we are not infrequently actually, especially when we have a very high index of suspicion and the testing is still pending, we'll actually go down and obtain a CT of the chest while we're obtaining the CT of the head, provided it doesn't delay matters much. Patient selection, again, this is a huge culture shift as far as like the way we've always been practicing neurointerventional surgery. Patients for whom there is clinical equipoise, such as those with anterior or posterior circulation, large vessel occlusion, and low NIH stroke scales. Patients with distal occlusions, low aspect scores, or minimal to moderate penumbral tissue should be managed conservatively. Patients with aspect score of 5 or less, or have poor functional outcomes, high rates of futile reperfusion should also be managed conservatively in the current climate. And these are, as far as like as painful as it is for me to say this, this is at this point the general stance that most interventionalists are going through, primarily because your goal is to save the patient, but at the same time, if by trying to help this patient, you realize that the likelihood of a good outcome is exceedingly low in the setting of a disease that is significantly like highly unpredictable, we should probably be managing these patients conservatively as opposed to offering invasive therapies or invasive surgery. Institutions enrolling patients in clinical patients with clinical equipoise for mechanical thrombectomy in randomized controlled trials have actually halted enrollment and provided medical management for patients for now. If the patient screens positive for symptoms, signs of COVID-19, all providers should wear PPE for any patient contact. In the emergency department and endovascular suite, team members assessing and treating acute ischemic stroke should be kept at a minimum to reduce exposure and to conserve personal protective equipment. Anesthesia and sedation, conscious sedation. Conscious sedation can be performed in patients where there is low risk of intraprocedural conversion to general anesthesia and can maintain sufficient oxygenation without the use of supplemental oxygen. Because of the risk of undiagnosed COVID-19, conscious sedation should be considered first line rather than general anesthesia for all stable patients. Because once they're intubated, it becomes very hard to extubate them. And when you do extubate them, you need to make sure that there's no microaerosolization. General anesthesia, randomized controlled trials have shown that general anesthesia is safe for patients undergoing mechanical thrombectomy, and hence should be considered for patients with severe disease, especially if they have respiratory failure, need oxygen supplementation to maintain oxygen more than 92%, PaO2 more than 60 millimeter mercury, and active cough should be intubated in a negative pressure room prior to transport to the neuroangiography suite. Extension tubing should be set up to avoid circuit disconnection, and ventilator transfer once in the neuroangiography suite. Providers should aim to avoid suctioning and disconnecting an intact system with a ventilator, again, to minimize aerosolization. Mechanical thrombectomy and room setup, providers should perform all mechanical thrombectomy with the presumption that all patients are COVID-19 and wear standard PPE. I can tell you at this point, the way we practice is everybody is COVID-19 positive until proven otherwise. Luckily, we have the 2-hour test, so if the patient's being transferred in, we usually ask for it to be tested. If not, then the patient's getting the test done at the on arrival in the ED, and as they're being rolled in, depending on when the test was drawn, occasionally we can get the results in as soon as almost an hour. Prior to mechanical thrombectomy, all necessary equipment should be removed from the neuroangiography suite. So all of our coils, all of our mechanical, like our stent retrievers, everything's been removed so that not everything is exposed. And we essentially have, we split our team into two with a hot and cold staff. So the hot is the supporting staff that should be identified as those exposed to the patient, and cold, or those who are not exposed to the patient prior to the procedure. A cold nurse or technician or technologist should be available in full PPE in the control room in case additional supplies are needed, or if the hot technician becomes contaminated. Simulation training with the entire team should be performed to help identify early issues and improve team preparation. If emergent intubation is required during the procedure, all personnel should leave the room except those essential for immediate patient care. Signs should be placed in the neuroangiography suite indicating an ongoing procedure on COVID-19 positive patient or suspected patient. I can tell you at this point, in our shop, what we do is we have one room that is designated primarily for COVID-19 patients, and we share that with our colleagues in interventional radiology. Cardiology is essentially done the same thing. There is a single room that is designated for COVID-19 patients. Post-procedure, there should be a minimum 30-minute delay before cleaning staff enter the angio suite to allow for settling of any microaerosolization that could have occurred. Terminal cleaning with EPA-registered hospital-grade disinfectants must be performed between patients. This includes, but is not limited to, disinfecting the floors, the walls, all surfaces, especially high-touch areas, cables, anesthesia machines, and trash receptacles. These are just sample cases that we've done over the past few months. This is another case with a very large clot that we were able to retrieve. As you can see, another very large clot. This patient had an NIH stroke scale of 25 with significant improvement. Another improvement in successful mechanical thrombectomy. This was a tandem occlusion. This was a case we did not long ago. Left M1 occlusion with TICI3 recanalization. This clot, believe it or not, was almost 16 centimeters long. I'd like to use the last few minutes of my talk just highlighting a very important, or sharing a very important public message. In a study that looked at almost 200,000 patients undergoing imaging processed with rapid software in just above 800 hospitals in the United States, we noted that there was approximately a 39% decrease in cases or incidences where the rapid imaging was utilized. This is typically, this primarily indicates that people are not coming to the hospital. And it's very important. It's very important that we emphasize the be fast and to emphasize the early identification of stroke symptoms in the community. Many patients could be asymptomatic. Delays in the hospital, hospital to hospital, and inter-hospital transfers should be anticipated. It's important to be proactive in obtaining requests. Consider any patient undergoing endovascular therapy being COVID-19 positive. Separate COVID from non-COVID COVID patients. And at this point in our hospital, if you are tested COVID positive, you are in an entirely different building. In a COVID, you're placed in a COVID unit. If you are negative, you're placed in a completely separate building, and there is no overlap whatsoever. Yes, there is a risk of stroke in young COVID-19 patients. The limitations, however, of this data is that it is stemming from case reports and case series and should be noted. But remember, strokes always can occur at any possible age and nobody's immune. This is a